Okay, looks good. Karen, just a heads up that there are 2 slides with Juta's biography at the end.
Yes, I did. So I'm
Just
just
in case
speaking to Uta. She's, I think, just struggling to join, but she'll be with us shortly.
Okay. I have sent her a link in her emails. So if she wants to join using that, that might be easier.
Yeah, I did tell her about the link.
Oh, perfect. Okay. Thanks.
So let me just let me. Yes, you are. I can see you there. Yes.
Recording in progress.
I can also see you, Uta. Do you want to check your audio?
Karen, I'm just checking. Can you hear me now?
Yes, we can hear you now.
Yes.
Okay, thank you.
Would you like to quickly test your slides before we start?
Sure. Let's see. Share. Okay. Can you see them? Not yet.
Not yet.
Okay. I think it's coming now.
Yes, we can see them, and you put them in slide mode.
Yeah, it's working.
So for us, it's not in slide mode yet, Uta.
Oh, for me it is in slide mode.
So maybe you must just do that swap thing. Different screen. So share the screen, which it comes up in.
Slideshow. No. Can you see my slides now?
Not, we
No.
can see nothing at the moment.
Okay, let me just see. Okay, you should see something.
We're seeing the slides, but not in slide mode.
Okay, putting it in slide mode now.
We're still just seeing the slides.
That's odd. See all slides, no.
So
Presenter view.
it might be better if you stop sharing and then you go to the PowerPoint and you put it into slideshow view. And then when you share your screen, you choose the slideshow window that comes open.
Okay, let me see. Okay. Okay, I've got it in slide view now.
Okay, perfect.
Let's try again. Okay, what do you see now?
We're still seeing your slides, but they're not in slideshow. Perhaps go to the top there and go slideshow.
Top, new slide, no, slideshow, top. I've got file, home, and new slide. No,
No,
layout.
so, Uta, it's not that. So how many screens are you working off?
Just one.
Okay. When you share your screen, not the PowerPoint. Just try that.
Entire, it says then it says Windows and entire screen. That's the only options I have.
Do the entire screen.
Okay. Share.
Okay, put it in slide mode now.
Must be my new computer. Look, I'm in slide mode on my side. It's odd.
Do you
Hi,
want
Ute.
Yes, hi.
Hello, everybody.
Yes,
What happens
hi.
if you click on slideshow at the top? What happens then?
Okay, let me just go out again.
Gary Gordon seems to think he has an answer for me. It's a setting somewhere. I'm sure it's a setting. Garrick, can we unmute Garrick? Maybe he has the answer to the universe.
Okay, let me just see. I see here slideshow. I want to see if this works. Windows.
We're seeing the slides, but not in slide mode.
Yeah, it's. I
If you
don't
now
know.
click on from beginning, from beginning at the far left. No,
Let's go out.
without closing it, without closing it.
Okay.
But you see, the thing is, Vernon, for her, it's in slide mode, so she doesn't see that from beginning.
Oh, I see. Okay,
Yeah.
that's strange.
There's
That
a
is strange.
setting. Uta, do you maybe want to email the presentation to me?
Yeah, maybe let me email it to you.
Uta, I think send it to me and then I'll share the slides once we've done with the introduction.
That's even better idea. Garrick, you have a hand up. I'm not sure if that's a hand because you can help us, or whether it's a hand to say hello, or whether it's a hand to just ask something else.
Okay, I'm gonna share the introductory slides in the meantime, and perhaps we can start while Uta is sending me her slides. Okay,
That's
Karen, I'm giving you remote control.
Okay. All righty. Good afternoon, everybody, and welcome to another Monday Heme Deep Dive. As always, it's a great pleasure for me to chair one of these sessions. I am very excited often about them, although sometimes they are over my head. And I'm especially excited to be introducing Uta and the work that she and her team are doing in some of our specialized laboratories. But before we get there, another little thing. Oh, there we go. Too many. Go back. Okay. Just some housekeeping notes. Firstly, as POPIA requires, we are disclosing that we are recording the meeting. And then secondly, that you can find these recordings at the Blood Assay website. During the course of the presentation, if you can please capture your questions in the chat box. Some of them we will, or your comments, some of us will be able to respond to, but at the end of the presentation, we will then review and make sure that we've gone through all of them. It's very nice to be on this mailing list because there are often quite a number of interesting topics that are being presented, and some of them are highly, highly technical that I think only a few people understand. But in general, there are some really good ones that I think appeals to a broader audience. So it's nice to see what's happening. And then the CPD points, CPD points are done automatically. It's very cool, but you need to be here for the whole hour. And then there's usually, I ask that people who are not presenting mute, thank you. And then there's a anonymous feedback survey at the end of each meeting, and people's honest and constructive criticism and recommendations and expressions of what works really well is very useful for the team to be able to tailor future content to the needs of the people attending. And then also very excited to remind everybody about the 16th Annual Hematology Oncology Symposium. We'll be in Cape Town. And I think I've seen, besides the fact that I'm talking on platelets, there are some very interesting and exciting topics and some really world-renowned speakers. So I think it's really worthwhile attending. So I would strongly urge everybody to see if they can make their way there. Then I think it's to introduce Ute now. Doesn't want to go. Let's see. There we go. Oh, first, before we introduce Ute, as always, the management team of the Monday Heme Deep Dive are really, really cool, and they are very organized. And so we would just want to acknowledge Estelle and her team for all the hard work and exceptional quality of the work that is put into contributing or to putting together the program, firstly, but then also on the execution of it. So thank you very much and well done. Then, as I said, our topic today is going to be molecular advances in red blood cell testing. Dr. Ute Jensch, who is our lead consultant for specialized laboratory services and pathology in SANBS, will be talking to us about this. Ute is a very experienced medical microbiologist, but I think it's unfair to call her just a medical microbiologist. She has been overseeing and has led the growth in the specialized laboratory services in SANBS in fields that are not at all related to microbiology, including cytogenetics, immunohematology, quality control, tissue immunology, and has really done a lot of work in transforming all of those laboratories into truly world-class, state-of-the-art 21st century testing facilities. But the other part that I didn't see here, which I'm not going to read through all of this, but I think the other part that I think is quite important to note is that Ute drives infection prevention control in SANBS and has over the last couple of years really turned around the way that as an organization we see and implement and monitor IPC and microbial surveillance in SANBS, which, if you guys know where we came from and where we are now, I think would surprise a lot of people and is greatly thanks to the work that Ute has done. Of course, there is the Fogarty program that we've done in collaboration with Estelle and her team at UCT. But I think most important for this afternoon's discussion is that Ute is the South African PI for the Blood Genomics Consortium, where there are multiple international collaborators. And the work, I'm very proud of the work that our team have done in this area. And I'm sure, I don't think I'm exaggerating, Ute, when I say that the work that SANBS has done has really enriched the assay and array development that they are busy developing as part of this consortium. So with that, I'm going to hand over Ute, and thank you very much for agreeing to do the presentation for us.
Good afternoon, everybody, and thank you very much for giving me this opportunity to speak on this very exciting topic. We live in a world of change, we all know that, and in the laboratories, we see an evolution from one technology to the other, and we definitely in the world of genomics. So this is an exciting topic, and I want to thank Karen for giving my disclaimer. I'm not speaking here as a hematologist. You can weigh in there, you can correct me and teach me, but what I will be sharing with you is the journey that I have been really privileged to be part of in getting a platform accredited for red blood cell, platelet, and white cell genotyping. So what I'm sharing with you is my journey, and it's by no means complete, but I hope that it will enthuse you and excite you about the era that we are living in. So, Karen, thank you very much for driving my slides, and I apologize that I can't do it myself.
So
Good.
It's not me. I think it's. Are you going to share?
Hi, everybody. I haven't received Uta's slides yet.
I didn't send them to you. I sent them to Karen.
Okay.
Okay. Yeah, they should be with Karen.
Just give me a second. I will start. If we just do this, and then I will. I should be ready to share. There we go. This away. Can you all see?
Yes, it looks great.
Okay. Can I progress, Uta?
Yeah, I don't have a full slide on my side, which is a bit problematic because I've only got it in small mode. Let me just see what I can do. I can enlarge this. Original size. Okay. Sure. Gee, this is. It gives me view options. I can do original size, but then I still can't see.
What is it that you're trying to see, Uta?
I'm trying to see my slides, and all that I can see is like a 5 by 5 centimeter version of it.
Your slides within Zoom.
Yes, in Zoom. Okay, they sort of cut off. I can't see the whole. Hang on. Yeah, now maybe it's better.
I can see the whole image, or what looks like the whole image of the slideshow on my side.
Okay. Okay, Karen, just go to the next slide. Let me just see how it switches over. Yeah, strangely, I can't see the whole slide. Sort of cuts it
Ute?
off. Yeah,
Ute,
yeah.
may I suggest that you minimize your Zoom window? Just open a new PowerPoint
Yeah.
that you used to work on, and then Karen can forward on the Zoom side.
So you open your slides on your side, Uta, and then you just tell me to go to the next one. When you go to the next one,
Okay.
I will.
Yes, I got you. Got you. That's a good suggestion. Okay, that should work.
Sorry, this is what happens when you get what you ask for. Uta needed a new laptop, and we gave her one, and now she's got this mess.
Yeah. Anyway, okay, good. Okay, we are ready to start now. So I'm on my first slide. I've told you about myself, told you about the topic. So what are my objectives for this lecture? Is firstly to give you a background to genomics, specifically in the transfusion field and how it relates to our red blood cell testing. Also, I think we really have to circle back to the foundation of transfusion testing using serological techniques and understand what the limitations are and why red cell genotyping is so exciting and how it fills those gaps that we have at the moment. And this really speaks about the problem statement, about current blood matching using current techniques. And then as we enter the genomics era, how do these molecular advances in red cell testing, can they assist us? And even within the genotyping, we have evolved from genotyping to sequencing and NGS. And I think we talk about these terms very loosely, but they are different, and they do indicate the evolution of this type of testing. And then we will look at some specific indications of genotypic analysis for transfusion purposes. There are a few examples, but there'll also be one slide on sickle cell disease. And lastly, I'll give you a little short tour about the Blood Genomics Consortium, and then leave you with the Sanders testing menu. Next slide, Karen. Okay. Yeah, so this slide really shows us what's been happening in the last 30 years. So while we were working as doctors or in laboratories or qualifying, a lot of money has been invested, up to $3 billion US dollars in genotyping, and specifically in the completion of the Human Genome Project, which came to its fruition in 2003. And what this slide shows is, when we do a paradigm shift in medicine or in laboratory techniques, it obviously takes time, and we always have the feeling this will never come to the patient bedside. We'll never see this test in our laboratory. It is so expensive. And yet we see again and again, and I think it started in the 70s and 80s, even just with plain PCR, is that over time price does decrease. And here you can see in around the year 2000, the cost of one whole genome sequencing was about $100 million US. It's just, it's totally unaffordable. And yet if you look about 25 years later, this cost has come down to about $100 US. So what has driven this? Firstly, definitely innovation, improvements in innovation, and then computation of all these techniques as the information that we gather can be processed and analyzed in big computer systems. Also, a big factor has been scalability, that these tests can be done at high volume. And obviously, there has been a lot of supplier competition. And lastly, the methodology of next generation sequencing really encompasses all of these advances in providing us high resolution results by testing using a technique called deep sequencing. So slowly the benefits of genetic testing are becoming integrated into routine patient workup in most areas in medicine. And really the aim of this is still with the patient in mind, that we can make more accurate diagnoses leading to earlier interventions, and hopefully through that improving quality of life for patients with various genetic disorders. So I think what we can say that this type of precision medicine is entering the field of transfusion medicine too. Next slide. Okay. So even as I speak now, for definite and high income countries, but even in South Africa, and some of these tests are being done at Sanders, we can offer genomics in transfusion medicine, specifically in the prenatal area, in the field of chronic transfusion, transplantation, and oncology. And already today, blood group genotyping in South Africa augments and may even one day replace serological testing in the environment we are working now. More specifically, genotyping allows for the detection of rare blood groups in a much simpler and more cost-effective way, actually, than long algorithmic testing using anti-sera and other special serological techniques. So where do we want to be in the future? So in the ideal future world, we really want to have our patients' extended blood group profile as part of their medical records. As we open the patient's file, as we can see blood group A, we want all the details of red cell, platelet, and white cell genotyping in that record so that we can determine best matches for transfusion or even transplantation at any time. Next slide. So as I said, before we go into the world of genomics, we need to understand the serological world too, and really acknowledge that over 125 years of researching of amazing people and scientists in the field like Landsteiner in Vienna around 1900 have really laid a sound foundation of understanding blood groups. And today, in our era, about 100 years later, and more specifically in terms of specific laboratory testing in the last 60 years, our testing has really depended on serological testing. And I would say it is fair to say in South Africa, serology is still the gold standard for all the decisions we make in terms of blood grouping, in terms of identifying rare groups and investigating special cases. So we have a solid foundation and we are now ready to move on. So just to remind all of you that a blood group antigen is defined as a polymorphism on the surface of red blood cells. And these polymorphisms are encoded by many, many genes. And in terms of the antigens and the genes, they differ significantly between populations and individuals. So in our environment, South Africa, we're already thinking we have lots of ethnicities, and obviously we are special again, and we need to make sure that all our genotypes are covered as this area evolves. So coming back to the serology, these antigens stimulate the production of an immune antibody response following exposure to non-self antigen via pregnancy or blood transfusion. And this results in antibodies that on occasion make patients untransfusible. And it's really a consequence of the serology not being sensitive and or specific enough, and thereby the body is exposed to non-self. So over 100 years, this field has evolved from the ABO blood grouping system to 43 blood group systems, and actually there are more already, and 48 genes, and these all represent more than 300 red cell antigens in the extended blood group antigen system. So you can see it's a very polymorphic, polygenic environment that we are working in every day. Next slide. Okay, back to basics again, just for all of us. It's always good to understand what we see if we shake a tube. And really the basis of serological matching has been, as you can see in the diagram, maybe first at the bottom, if we want to look for incompatibility, we basically look for agglutination, we look for clumping. And how does that come about? So on the one hand, you will have your donor red cells. So this is the product that you will be transfusing, and it has the red cells with its antigens, and you have your patient. So this is a very simple test. You mix the cells with the serum. This is what we call an immediate spin test. If there are specific antibodies, they will latch onto the antigens on the red cells. And on adding anti-human globulin, you form a network where the antibody produces this agglutination complex. So this is an incompatibility and is seen as a red dot at the bottom of a tube. While if there are no specific antibodies, you will just have, the normal color of, diffused color of the blood. So this testing we do in the laboratories using reagents or antisera to all the different and common and clinically significant blood groups that we know of. And this is a standard test that happens in the blood bank. And it can be just for the detection of your very simple A and B and AB antigens, but we also have special antisera for the more rare blood groups too. Next slide. So the next slide already brings you a little bit closer to DNA-based testing, and this is a table from Professor Connie Westhoff's publication. And this is another benefit from this journey for me, is to really interact with capacities and scientists who are really experts in this field. So if we compare antibody serological testing to DNA testing, what is really the difference? Obviously, the antibody-based agglutination test is very simple. You can do it very quickly, while DNA-based tests need much more preparation, DNA extraction, and at a minimum have a turnaround time of about 24 hours. Antibody-based techniques are generally manual, although in our laboratories, these tests have also been automated, and you do get automated versions as well. The DNA-based tests generally are automated. So one of the complexities with antibody testing is that you always need a fresh sample, while with DNA testing, all you need is a good DNA source. And that already tells you DNA tests, once you have a result, that result holds. For another transfusion, you would not have to get another sample. However, for antibody-based testing, especially in the chronically transfused patients, you do have to repeat this testing because of the potential of sensitization in the past. Obviously, in terms of equipment, there's a big difference. The DNA-based typing platforms are highly complex. They have a big integrated computer element and software, so much more complex than antibody-based testing. The antibody-based testing, depending on which anti-sera you will use, will give you antigen specificity and tell you which antigen it is directly, while with DNA-based interpretation, it is more indirect. You get your genotype, and from that, you predict your antigen expression. But I can assure you that there's enough information in the literature for this prediction to be highly accurate. We also are aware that in terms of red blood cell testing using serological techniques, in the era that we treat our patients in, many patients are on highly sophisticated medication, which interferes with red cells, binds to specific receptors, and therefore interferes with serological testing, giving very confusing results. This type of problem you don't have with DNA-based testing. In terms of serology, we know that for some more rare blood groups, there are no reagents available, no anti-sera available, or very difficult to source or very expensive. And we have for definite experienced that in our immunohematology laboratories. And these include, for example, the anti-LAN, the anti-U, and the anti-HRS. This issue, obviously, we don't have for DNA-based testing. Obviously, sensitivity of the serology is an issue, specifically if we deal with weak or variable antigen expression, and you may miss some antigen types. This is not a problem for DNA-based typing. So just to add to that, so although genotyping is expensive, anti-sera is also very expensive, especially if you have a complicated case and you have to follow various algorithms. You actually, in many cases, genotyping is more straightforward and more cost-effective. Although in our setting, we generally use the two methodologies together. I think the rest I have mentioned already. Good, we can go to the next slide. So I think by now and I think you know already what the issue is with blood matching is because of the serological tests and the issue around sensitivity and specificity, missing weak antigen expression or not detecting certain antigens. Our patients may form antibodies unnecessarily, and if they are repeatedly transfused, they may become untransfusable. We struggle to find compatible blood, and this is a very real problem, specifically in the in the divisions that you work in, hematology and hem-onc. So if we look at the prevalence of this problem, basically patients will start off with quite a low percentage of risk of forming antibodies against one or more antigens, probably around 3% after a single transfusion. But we all know that many of the patients you deal with, they are transfused repeatedly, and many of these patients may show up to 60% sensitization. So this is truly a real problem. Next slide. How can molecular advances in red cell typing assist? How can the molecular typing assist? So the bottom line is that molecular typing of red blood cells is a truly realistic opportunity to improve blood safety. But it really depends on having like a critical mass. One has to sort of do this consistently in the patient populations that we serve, and ideally do this in donors and both patients. With molecular genotyping, you can build a safe, sufficient stock of blood negative for high frequency red blood cell antigens. And also, as I've mentioned, it is extended typing. It's once off and will reduce the rate of alloimmunization. Red blood cell genotyping expedites future pre-transfusion testing by narrowing the number of different antibody specificities that must be ruled out. In our setting at the moment, because we can't do this holistically for our donors and patients at this point in time, we apply genotyping in inconclusive blood grouping results from serology that are ambiguous just by serological testing. At a global level, this field has now a few decades of experience with the prediction of the red cell phenotypes by DNA assays. Next slide. We have quite an acronym in South Africa at the moment still, where we mainly use serological methods. If we don't find compatible blood, we issue the best, least incompatible blood. And hopefully one day we will be in a similar situation to many high-income countries where this is no longer considered best practice. So countries like in Europe, Australia, and in the US, DNA arrays are available in most bigger blood centers or larger hospitals. And especially if you have a high throughput system, you can do the extended phenotyping or genotyping of your donor samples. And an added benefit would be if you can do the same for patient samples, so you match truly at a genomic level. I've talked about the costs earlier, and although the costs in our environment are still prohibitive, specifically if we're looking at NGS, I do believe, and it is my vision, that the costs for genotyping and NGS will continue to reduce over time. So this is definitely a goal we should have in mind for both our donors and patients. Next slide. So why is genotyping so useful? And the main reason is, and what one needs to understand, is that most blood group antigens, other than ABO and RD, result from a single nucleotide polymorphism. So it's just the change of one nucleoside. And therefore, if you can detect this SNPs, if you can detect them, you can make genotyping a logical approach, because it's like reading the DNA and just trying to pick up this SNP. Evolved from serological phenotyping to genotyping. And with the genotyping, these are generally probes. So you're not sequencing or reading a whole genome. You are just looking at very specific areas where you know what the variant is, and that probe will then check for that variant, be it in the MNS group or in the RH group. So these are probes that are limited to known variants. While genome analysis and next generation sequencing reads the whole genome, and in that way gives you a much better and deeper analysis of the whole gene encoding transfusion markers. Also, genotyping will detect very low levels of antigen expression or partial expression of antigens, which are easily missed by phenotyping. So this has really resulted in the last 10 years in the commercialization of DNA arrays that target up to 40 antigens in 12 blood group systems, but not only for red cells, but even for human platelet antigens and also for HLA. And this testing is usually done on one platform in one test. I've just tried to summarize here what the difference is between genotyping and sequencing, and most of it I've already said. So the genotyping, just to repeat, is DNA analysis for specific known nucleotides using very specific probes. So in this way, you will detect only very specific variants, but it will miss variants that haven't been probed for, that haven't been described, or any null alleles. This problem is overcome by sequencing, where the genome will be read for both known and unknown variants. Genotyping, although very useful, generally only produces small amounts of information from DNA, while for genome analysis and NGS produces lots and lots of DNA information. Just some examples for genotypings in terms of platforms. So I've talked about the PCR probes. That's what we are quite familiar with. But there are also other technologies like FISH and restriction fragment length polymorphisms, which also are a form of genotyping. Sequencing started with Sanger sequencing many, many years ago, and this has evolved to NGS. And we use this term very loosely, but I think what it really is, it's really massive parallel or deep sequencing. So you get much, much more information, and you have the genome that is cut off, and you get this parallel sequencing of all these little pieces of the genome at the same time. And then this is then interpreted and sorted through very sophisticated software. So this has really, NGS has really revolutionized sequencing. And just to give you an idea, apparently the whole human genome can be sequenced within a single day, just showing you the advantage of high throughput, high resolution, and also in this way, making this technology, although still expensive, but it will become more and more affordable. Okay, next slide. On this slide, I won't take you through the slide word by word, but it's just a nice reference if you want to look up a little bit more about genotyping and sequencing. And the pictures there on the right are just showing you with the probe, you could easily detect this SNP very easily. So let's say the normal situation would be a cytosine guanine. And with the variant, the cytosine has been replaced with thymine. So if you have a probe that just probes for that part of the genome, that is what you would detect. With NGS, you would just read that whole sequence, and then you can compare the sequences across different samples or patients. So what are the indications for genotypic analysis for transfusion purposes? So this is just bringing it into the clinical field. So firstly, for us in the transfusion center at Sambers or Western Cape Blood Transfusion, we use this for determining blood groups of our blood donors, not as a first off test. We use it in very specific informations, for example, to confirm weak RHDs, which can be missed serologically and lead to alloimmunization. That would be one indication. Also, sometimes donors have depressed ABO groups. So again, you can't determine them serologically, but the antigens, the genes are actually there, and you can determine the correct blood group of the donor and retain them in your donor profile. And also, I have mentioned that if we have donors that we cannot characterize fully using serological techniques, then we do combine our serology together with genotypic characterization. And this is important because we have lots of ethnicities in our environment. And also we house the rare donor database and rare units in frozen storage, and we utilize or we apply genotyping in our screening for rare blood groups too. Then obviously in the patient setting, ideally you would want to do a once-off very early, before all these multiple transfusions happen, pre-transfusion testing of your patient to determine the original blood group, because there may be a transplant, there may be sensitization for whatever reasons. There may be you as a doctor providing biologic therapies that interfere with serological testing. So if you have your genotype in that scenario, it will save you a lot of headache. We experience in our scenario that the clinicians will phone because we can't determine the blood group correctly, because now the patient is already on rituximab or a similar drug. So I do believe that going forward, we will be applying much more genotyping as part of standard investigation in our hem-onc or transplant patients. I have already mentioned that this type of testing is a once-off test, generally utilizing an automated assay. And obviously, it's not about just running the test. It's very much about also our staff being reskilled and retrained in analysis of the genotyping results. So as we move to these technologies, we also have a responsibility to upskill our staff and ensure that they are highly proficient and competent in interpreting the results that we get. It is very different type of laboratory to a serological lab. And the good thing is, obviously, if you have that testing, it expedites future pre-transfusion testing needs. The third indication, already talked about this a little bit, is obviously in the field of organ transplantation. And this really adds to the blood transfusion support. So basically, again, pre-transplant testing, blood grouping, HLA typing can be done using this technology. And we are even improving in terms of the type of specimens that we can test. So you can even use a buccal swab. I said as long as you get DNA, that is fine. We know you need not always have blood samples. So specifically for HLA testing, we often use buccal swabs. Also, with transplants, there's occasionally a need either to look for engraftment of now a new blood group, or you want to look at what the progress is with engraftment, or what has happened, or determine the original blood group. So this is also something that you can do. And then fourthly, again in the same patient group as I've mentioned, patients on monoclonal antibodies. So this little picture shows you here that the monoclonal antibody therapies bind to the same markers, the CD38s, or now with the new drugs, the CD47, and thereby prevent the serological reaction to happen. We can ameliorize this in the laboratory by treating our samples with DTT. that is one way we can treat samples if we know patients are on this therapy, but normally we don't know. So we need that engagement with the clinicians to tell us. So if we're testing serologically, we can treat our samples with DTT. But a better way would still be to do the genotyping. And actually, the AABB recommends baseline ABO and RHD and antibody screening and performing extended red blood cell phenotyping or genotyping before the start of monoclonal antibody therapies. So this is really something we are trying to make our clinicians aware, and more we hearing about patients that we test that are on these antibody therapies. Okay. So obviously the other indication for extended antigen or genotyping is for in the setting of preventing hemolytic disease of the newborn. So here we can genotype pregnant females for ABO and the CAL system, and obviously the RHD, which is the main player. Other indications for extended genotyping or antigen matching include chronic transfusion setting, and I've talked about this extensively. And I just want to mention one clinical indication, which is sickle cell disease, and I will come back to this. So here the important genes are the RHD, C, E, and K. Transplantation we have dealt with. Apologies. Then the sixth indication is prenatal testing, and ideally this should be done non-invasively on cell-free fetal DNA and maternal plasma. In other words, using a maternal sample and isolating cell-free fetal DNA. And the value here is obviously you can determine the fetus's RHD group and assess the risk of hemolytic disease of the newborn. Just a similar scenario, we utilize HPA, so platelet genotyping screening in the setting of fetal neonatal alloimmune thrombocytopenia. So it's obviously not red cell typing, but platelet typing. And there are certain genotypes on the HPA that are associated with this condition. What I have here is just one slide on sickle cell disease. And in South Africa, I think we are also becoming more and more aware of the importance of phenotyping, or even better, genotyping these patients. Our problem is that these cases come to us very sporadically. We know that a big part of this population is quite nomadic and they only come to us or South Africa when there's a sickling crisis. Because ideally you really want to have this extended antigen profiling before a sickling event happens. So if you have a sickle cell clinic or are aware of these patients, this is something you need to remember and think of. And the genotyping at a first line should always involve the RHD, big C, big E, little e, little c, and K. So the benefits are obvious, but just a few specific points. So red blood cell genotyping identifies about 20% of patients with sickle cell disease whose red blood cells type C positive, but who have altered C antigen. So they should obviously receive C negative donor units because obviously they're still prone to sensitization and make anti-C. So with the genotyping, this may be missed serologically, but you will be able to identify this using genotyping. Also, it identifies patients who lack high prevalence antigens, and although prophylactic prevention is often not possible, having this information avoids misdiagnosis because the antibody and the laboratory testing may appear just as a warm autoantibody. So you get more specific and defined information on the red cell antigens. Furthermore, it detects incompatibilities in other clinically significant blood groups for which antibody detection may be difficult or not available. So I talked about the first-line antigens, which are mentioned above, and here you have all the other potentially clinically significant blood groups, where you will get information on if you do full red cell genotyping. Also, this gene, Rh gene, is not straightforward in our environment, and even in the BGC, although genotyping has proven to be very good, one of the problem areas is within the Rh gene. So definitely the Rh gene in African patients hasn't been fully understood, let me put it in that way. And serology is not always reliable, especially in these multiply transfused sickle cell disease patients. So patients with sickle cell disease sometimes make rhesus antibodies despite DC and E antigen matching by serology. So probably the best you can do for your sickle cell disease or trait patient is definitely to invest in a genotyping profiling. The other benefit of genotyping is to use rhesus immunoglobulin more effectively and more cost effectively. So in South Africa, where we are still in the serological era, what do? We give Rh immunoglobulin to Rhd negative women antenatally, and we give Rh immunoglobulin to the Rhd positive baby after birth, because generally we don't have that information available prior to birth. And we are not able through serology to differentiate between Rhd negative from partial or weak Rhd. So within the Rhd group, there is a subpopulation that is either weak, it's either a weak D or it is a partial D. So the weak Ds are not a candidate for rhesus immunoglobulin, while the partial Ds do lead to allosensitization and are candidates for rhesus immunoglobulin. So in high income countries, what is being done there, these countries use non-invasive testing of cell-free fetal DNA in maternal plasma to determine the fetal Rhd type, and in this way avoid unnecessary administration of antenatal IgG to about 40% of women who carry an Rhd negative fetus. So that is obviously a nice thing to have, and I do think this would be a nice project for us in the blood service to do, is to start looking at non-invasive testing, cell-free fetal DNA. And then just coming back to those it's quoted. So this is a study again from Professor Connie Westhoff, where she gave the results of about 350 women. They were from different ethnicities, and where they looked at the distribution of the weak versus partial D alleles. And if you apply genotyping and you can separate the partials from the weak Ds, you can then obviously also eliminate the weak Ds who don't need rhesus immunoglobulin. So this is also a good application of this technology. Okay, so what do we do at SANBIS? So we do genotyping for red blood cells. We don't do NGS at this stage, although we do NGS testing for HLA. So at SANBIS, we use two different platforms for genotyping, and we use them collectively so that we cover most of our query samples in the best way that we can. It doesn't mean that we always find an answer, but following extensive phenotyping and then going through to genotyping, we have two systems. We have a Luminix system called the ID Core, and then a Flow Gene, which focuses on ABO, and then we have another Flow Gene kit which focuses more on the RHD system. The Verify Extend looks at a whole range of blood groups, and they are listed here, so that gives us good coverage there. And then we also have a very specific flow gene test called the ZygoFast, where we can differentiate heterozygous from homozygous results. And this is often important in paternal testing and working out the risk for a baby in terms of their RHD gene status. So just to remind you, this is a type of probe testing that we do. So it is based on determining known sequences or variants thereof. It gives us relatively little genetic data compared to NGS, but it is definitely a good add-on to what we do. And where we still come short is that we still have a high number of variants in the RHD group, where we struggle to come to a final conclusion, and even the MNS group, we are left with a few discordancies. So as you can see, genotyping is useful, but you have to use a multiple of probes to cover most of your variances and sequences. So we use this testing for serologically ambiguous cases, for RH group queries, also suspected rare blood groups, occasionally for sickle cell disease, red blood cell genotype characterization, and RH group specification. Good, that's the first part of my lecture. And what I will do now is just share a little bit about the Blood Groups Genomics Consortium. This is a very exciting consortium because it has collaborators in all continents, and it started off with 7 and then 10 countries contributing DNA samples for the validation and accreditation of a high throughput array, which in one test characterizes red cells, platelets, and white cells or HLA. So you can see all the countries that are participating on here. Central to this collaboration is the University of Cambridge. So that is where the research lead is based, and from where the study has been coordinated. But then there were 2 further reference laboratories together with Cambridge, one in the US at the American Blood Service, where Connie Westhoff works, and the second one in Sanquin in the Netherlands. So those 3 laboratories did the testing in parallel. So every DNA sample was tested in triplicate, and all the countries contributed DNA samples from the environment. And that was important because prior to the accreditation of this array, which actually only happened very recently, about a month ago, and it was presented at ISBT, before that, there was a publication that I have referenced at the end, but the weakness was that the ethnic spread wasn't really wide enough. So those are the collaborating partners. So as I've already mentioned, the objective was to deliver a comprehensive and affordable axiom or array for the typing of donors and patients for red cells, HLA and HPA in a single test, and to also improve the probe content of the array and render it suitable for use in donor populations representing the main ethnic group. So that this array has a good coverage and is not dependent from where the donor or patient in the world comes from. We need to have assurance that it has a good geographic and ethnic spread. And this accreditation is necessary also for Thermo Fisher, who is the maker of this array for them to get regulatory approval. So over about 4 years, we tested 18,000 samples, and the study had various phases. We had preclinical studies 1 and 2, which really optimized the array, optimized and ensured that all samples were quality controlled and met the DNA requirements in terms of DNA purity and volume. And then also the 3 testing laboratories obviously had to coordinate their testing, and following triplicate testing, all the discordances had to be separately looked at again. So we have now completed this, and the first outcomes have been published at the ISBT. So what do we get back in South Africa? So we contributed just over 2,000 samples, and we will get the results back for all our donor samples for all 3 markers. And I think that will help us to, we obviously had that information available for our donors, but it will help us understand our genomics better. I'm sure we still have a lot to learn, and we actually then need to analyze our own results. And we know at a high level that this array performs very well in our environment, but we would then want to look at the areas where, where our ethnicities still challenge us in terms of the genetic results we will get back. Okay, so this just shows you in one picture what this genotyping is really about. And it's all about the donor and the patient, and we want 100% matching for all blood groups so that we can have the best match for our patient. So what happens is that on the donor side, donors will have a blood sample collected as they would have for normal blood grouping. This blood sample would go through a genotyping array, and the blood typer is the software that will then interpret, will analyze the results and assign a blood group and relate it to the phenotyping as well, because that is generally the result you already have in your database. And then your genotyping information will sit there. If a patient in the hospital is in need of a transfusion, or there's a workup before a chronic transfusion program is started, the patient is also genotyped. The typing is also then analyzed through the blood typer software. But then the next step is that there would be a software managed best match between the patient and the donor. And then from there, the blood would be identified and then got to the patient. So this is obviously in the ideal world, and we are still very far away from this, but it's definitely a good vision to have. And it would really, give patients much better matching for their transfusion needs. Okay. This is just a bit of a diagram to show you what this array looks like. So you can think of a laboratory 96 well plate. And if you look at on the left, you can see all the markers that this array or this plate has. And it starts with, well, the typical ones, your H&A, that's your HLA, HPA, and where are the red cells? Red cell quality. Where are the red cells? Oh, blood groups. Here we go. That is sort of at a first view, but this array has actually been extended to add other DNA variants that are relevant for transfusion purposes. There's, for example, a marker for sickle cell disease, for hemolysis, iron accumulation, even things like restless leg syndrome, iron reserves, fainting, Many of these are not fully optimized, but this is sort of what a transfusion transplantation array will look like. So for the purposes of the BGC, we looked at least for the level of our consent was for the red cell, the platelet, and the HLA typing. But you can see how on one plate you can get so much information. And this array has been optimized over the 4 years, and for the accreditation purposes, the optimized array has been used. Okay. You can't see the detail of this poster or presentation. This was presented at the ISBT conference, and these are the very high-level results of approximately 7,000 samples that were tested for the accreditation of this platform. And for the purposes of this accreditation, the typing was based on 54 clinically relevant blood group genes, the 8 HPA types, and HLA class 1 and 2 using a first field resolution. So the strength of the study is that it's multi-center and that it has DNA samples from donors representing multiple ethnic groups. I just listed some of the key HEAs, the same as red blood cell genotypes, and these genotypes then were interpreted and inferred by the blood typer software that I showed you on the previous slide. They were also compared to previous typings that were available on the donor database in terms of serologic and phenotypic characterization. And basically, bottom line is, doesn't matter whether you look at the red cells, at the platelets, or the HLA, the concordance level between clinical and genotype inferred red blood cell types, but the same actually applied to HPA and HLA, was more than 99% across different ethnicities. So that is for overall for all the samples, and overall our South African samples also met this 99%, but we do have a few, as I've mentioned before, some challenges in the RHD and the MNS group, which we will explore further. Okay, so this brings me to the end of my red cell genotyping presentation to you. But before I end off, I do want to remind everybody about the testing that we do. In case you would like to refer some samples or if you have any queries. So I do believe we offer quite an extensive spectrum or menu of serological and genotypic testing for the clinical scenarios you work in, both in terms of organ transplantation. So as I've mentioned, we're doing first-line NGS testing for that setting. But we also do full HLA antibody investigations, cross-matching using either CDC or virtual cross-match. And we are looking at the feasibility of implementing flow cross-match too in our FE-accredited lab. Then obviously in Dr. Tanya's area, we have the stem cell and bone marrow transplant clinical services that are offered, but also some testing. Again, the HLA and the flow cytometry for the CD34, CD3 testing. We investigate thrombocytopenia, and I believe we're the only laboratory in South Africa doing the HPA antibody testing and typing. And we do get quite a few referrals for that. This obviously also falls into the field of fetal NAIT, and for fetal anemia, we do the anti-D and specific red blood cell antibody testing too. We offer a service of HLA, HPA matched platelets. This is available, but it's not like a 24-hour turnaround. It has to be planned and organized very well. Then we do transfusion reaction investigations using all the testing facilities we've had and that I've already referred to. I've also referred to the clinical apheresis services in terms of stem cell collections and plasma exchange and others. And in terms of blood transfusion testing, we also have a comprehensive blood transfusion proficiency testing program. So that's our menu. And then lastly, I think and I hope that I have convinced you that genomics is becoming highly relevant in transfusion medicine. We cannot stay behind. We need to stay on this shift as we're moving from serology to this era. It will continue, it will improve, it will become more cost effective, and hopefully one day we in South Africa are also able to type our donors and patients concurrently. I would like to acknowledge our SANBIS, IMH and R&D laboratories, and also my collaborators in the Blood Genomics Consortium. There are some references for you that you can look at. And I think this is the last slide. Thank you.
Thank you very much, Ute. I can't see the chat box. Let's just have a look. There's the Survey Monkey. Yes, please, for those from SANBIS especially, can we have the Survey Monkey completed? Then are there any questions? Are we all... Maybe then from my side, Ute, I think one of the things that we struggle with, especially when we're out in the rural places like the Eastern Cape, is for people to understand the process of ordering some of these tests. I don't know if you can maybe just take us very quickly through that.
Yeah. Okay, so in terms of ordering the tests, what is very important is that we get a requisition form. So we have requisition forms for these special investigations, be it HLA testing or red cell genotyping. And then obviously the specimen requirements are very important. They are listed on the requisition form, and the easiest would be is to get into contact with myself or with my managers in the different laboratories. So if you want to have those contacts, please reach out to me, and then we will assist you. And mostly the way the samples then come to us is if they can be brought to the closest blood bank, then they will come to us in Johannesburg or in Mount Edgecombe, KZN.
Thank you. I'm not seeing any hands at the moment, but maybe, I know you touched briefly on it, Ute, but perhaps you could just express or expand a little bit on the value that SANBIS and South Africa brought to the Blood Genomics Consortium. I think that, you know, the project is significantly more successful because of our participation, but maybe you can just explain
Yes.
how that really worked.
Okay, so obviously the genotyping and even NGS array testing in the transfusion setting has been happening for many years, and there was one landmark paper, the first one by Nick Gadol in 2020, which was the first paper that was based on the array that we use now for the accreditation of the Thermo Fisher array. But the problem with that publication was there were a few African patients, but they were definitely not from South Africa. So the big limitation is always, if you don't have all relevant ethnicities covered, firstly, it is of no relevance to us because we would miss a lot of important genotypes or variants. And secondly, even at a global level, you want to ensure that you are covering all relevant genotypes. So our contribution was significant in the sense that we added to the ethnic diversity of the overall sample pool. And if you think about it, for the BGC overall, we had between, say, 10 countries, 16,000 samples, and South Africa contributed over 2,000 to those. So that's significant. So in proportion to other countries, we contributed much more. And therefore, really stressed the robustness of the assay, if I can put it in that way. We had enough samples to bring up some very small remaining deficiencies within the array. Although, as I said, even for our samples, we had a 99% correlation with inferred phenotypes. So, yeah, I think our value is that we contributed samples. So that's important. And now that we will get the results back, we hope and we need to publish what we have found for red cells, for platelets, and for HLA.
Okay, great. Then we have
There
a
is-
comment from Benny Koen, genotyping for compatibility testing will not be conducive for more urgent emergency cases. Yes, that is
Yeah.
correct.
Yeah, that is correct. So as I said, genotyping should, in our setting, ideally be done preventatively. In other words, before you start patients on chronic transfusions, before you start monoclonal antibodies. If you identify a patient with sickle cell disease, get them genotyped because they will come back and need blood. So the testing, we do batch testing, and I think we test about twice a month. So it has to be planned at this point in time.
And then we have Jesse. Thanks, Dr. Utto, Dr. Jens, for the great presentation. What are strategies that blood centers may use to increase and expand molecular testing of donors for patient matching? Also, how would molecular methods may be applied if, despite genotype matching, the patient still develops an antibody?
Okay, I'll try. So what strategies should we utilize to increase and expand molecular testing of donors? So, I think it is all about international collaboration and playing in the same fields as the international experts. And I think we need to continue to do that and continue to do that better, because I think once we are involved and we participate in this testing and we can show the benefit, we can slowly move towards more expansive genotyping as we go along. I think for us in the BGC, hopefully we will be offered preferential pricing. In other words, that we can, we will continue to do our genotyping, but we can only afford to do next generation sequencing if we do this, if there's a whole paradigm shift and we move to genotyping our patients and donors in South Africa. So, but we can make use of that technology, hopefully through the BGC, where they give us reduced testing prices. So, so I think the international collaboration and playing in that field is very important. Obviously, in South Africa, we are challenged by pricing, by affordability, on all of that. But I think it should not be an excuse. I think we must just keep pushing those boundaries. And I'm sure you can all recall within your careers, at least for me, I grew up in the era of serology and microbiology, culturing bacteria. These days, PCR is standard and nobody talks about the price anymore. If you need a PCR, you do it. And in that way, I do think that this field will evolve. I also think the technology will become simpler. so that it is more robust and hopefully quicker as we go along. So what was the second question? Yeah, so if patients are sensitized, with genotyping, I do think there is still big value because you can't change the sensitization. You know, the antibodies will remain. They may wane a bit, but if there's some sensitizing again, that antibody may come up again. But I do think that through the genotyping, you will know exactly which antigens to avoid, which antigen negative units you must definitely look for, because you will have a full characterization of your patients. So I think it will still help with better selection of the best unit despite some sensitization.
Then we have, will genotyping eliminate the false positive reactions experiencing in serotesting, for example, patients on ARVs, septicemia, etc.?
Yeah, so Benny, this is a good question. Because genotyping reads the DNA, it's not affected by everything else that floats around and binds to antibodies and binds to antigens. So a genotyping result is very, very pure, if I can put it that way. So this is exactly one application where we use it, is to really know what's going on at a genetic level in a sample that shows a lot of interference.
Okay, I think that is it. I'm not seeing any hands, and there are no other questions in the chat box. With that, then, Ute, thank you very much for what was yet again a very enlightening presentation. Makes me very proud to be associated with SANBIS, the wonderful work that gets done there. And thank you very much for everybody who joined us. And also for Blood SA for hosting this wonderful event for us. So with that, I will close the meeting. Enjoy the rest of the evening, everybody.
Thank you very much. Bye-bye.
Thanks. Bye-bye.